Very good afternoon. Thank you, Tambu sir, for making this possible. And this is one of the first meetings I'm doing after the COVID pandemic. So this was planned actually way before that. And the idea was, sir actually asked me if I can talk to you all about what is immunotherapy in cancer. Now, as you all know, you all must be following all the latest journals, right? Lancet or NEJM. When you get the emails from these journals every week or every month, one or two articles you will see in that will be on cancer immunotherapy. So much so that in the last 2 or 3 years, we've had a huge number of clinical studies which have been conducted and published, and the picture is changing rapidly, and this is not only happening in one or two kinds of cancers but across different cancer types. So today in this short talk I would not cover in detail about individual cancers. That I think I was talking to sir, and then maybe we can not only immunotherapy, we can actually do one cancer every month in the coming days, so that at least you all have an idea when you see your patients and when you make the diagnosis, because many times the diagnosis is made by registrars in the ward and in OPD. So we'll just cover basics, and I would go slow, and then if you all just raise your hand, and we will stop and we'll discuss further if required. Now, right from our pathology days, this picture is from the textbook of Robbins textbook of pathology. We have people have realized that cancers are difficult to treat. That is because they are very different from other cells, and what makes them different from other cells are because it's their ability. Number one, we all know about how they can keep on replicating, how they can evade growth suppressors, how they can survive even if there's no oxygen, how they can survive even if there's no glucose. So they are they keep undergoing mutations. Their genome is unstable. They have the ability to transfer and traffic throughout your body. Like a cell can actually pierce the endothelial cells, go out in another organ which is entirely foreign, and even in that organ it's able to produce angiogenesis, get its own blood supply, and from one cell develop a full-blown metastasis. So these are all extraordinary properties which cancer cells have, and it's because of these multiple properties we finding it difficult to treat. And since a long period of time, scientists or in the lab have actually focused on trying to kind of attack these properties so that we can cure cancer. And one area which was known for a long time, but it was kind of no progress was made, was the cancer cell's ability to avoid immune destruction. When I say avoid immune destruction, I would just show you a small clip. This is actually a lab-based cell culture. And here, what you see here, this green cell is your T cell, and this blue cell is a tumor cells which is growing in your culture plate. And I'll just mute the audio so that. And what you can see here is how your own T cell is engaging your tumor cells, like the way it will engage a bacteria, like the way it will engage a cell infected with virus. And if you can see that this cell has identified the tumor cells, and it's kind of going to attach itself, and there is some interaction going on between the two. So it's like a fight going on between the two, and there are signals going across, like one cell is trying to invade, other cell is trying to escape. And finally, at the end of it, one of them is going to win this game, right? And in this situation, if you see here, this is the T cell which finally wins, and it's able to destroy your cancer cells completely. Now, if this is what we understand properly, if we have a proper understanding of this mechanism, then maybe we can enable our own immune system to attack every cancer cells, and maybe we can prevent relapse or even produce cure in some patients. But it's easier said than done, because this is not something new. This is like a review of history of cancer immunotherapy. If you see, that immune system is active against cancer was known even from like 1000 years BC, where spontaneous remissions of cancers were described. Later in the modern era, in the 1866, two German physicians actually described that they had a head and neck cancer patient who had a streptococcus infection, the erysipelas, and once he had a severe infection, and once that infection was treated, the cancer also disappeared on its own. The cancer was also in the head and neck region. So people knew that inflammation does play an important role in eliminating cancer cells. It's just that we didn't know how to harvest this. The father of immunotherapy, I think this is William Coley, in 1891. He actually developed the first cancer vaccine. But even and then various other discoveries, people tried to understand the immunosuppressive tumor environment, the antigen presentation, immune surveillance, etc., etc. But it's only of late in 2014 and 2015 onwards where the recent discoveries had led to newer drugs which are more effective and which are effective in a larger population. When I say larger population, I mean, see, this is way back. This is a paper way back in 1999. This was almost now, you can say, 20 years ago. Based on these data, this is high dose interleukin therapy. Interleukin, you all know, is a cytokine. It's involved in inflammation. So what you do is, if people realize that if you had certain cancers like melanoma or renal cancers, you take these young fit patients who can withstand this high dose interleukin, put them in ICU, give them interleukin infusion, cause a cytokine storm that can lead to almost a complete response in some patients. But these numbers are very small. Like, see, out of 270 patients treated, you will get a complete response in only about 17. That's a very small number, and this therapy itself will kill many because so therefore, even though these therapies were known and approved, but it did not make a major impact because most of the patients would not tolerate these kind of therapies. Now if you broadly kind of divide in what are the ways you can harness your own immune system to fight cancer cells, one is cytokines, which we just discussed. Other one would be cancer vaccines. Now, what are cancer vaccines? I mean, these are, again, you take the tumor, you identify some antigen, and you kind of process it in the lab and give it back to the patient. But here again, this has not been successful so far. The benefits are not long lasting in many patients. Then there is something called adoptive T cell transfer. Now, what is adoptive T cell transfer? Now, you take your own T cells, patient's T cell, take them into the lab and culture these T cells in presence of a antigen which may be specific to the cancer. Like, for example, if you have got a man with prostate cancer, you all know there's a protein called prostatic acid phosphatase, which is commonly present in all prostate cancers. So you kind of stimulate these T cells outside the body and go and give these T cells back into the patient. So there again, some benefit. I mean, this is an approved therapy called Slipilucel T in prostate cancer, but again, this is cumbersome. You need a lab which can do it, and it's not practically possible to do for everyone. There are a lot of other ways, like when you understand the tumor response and different cytokines involved. There are tumor inflammation promoting cytokines and there are suppressant cytokines. You can actually design antibodies which can be agonist or antagonist. Then off late you will be hearing a lot about CAR T cells. Now, what are CAR T cells? CAR stands for chimeric antigen rearranged. Now, these are genetically re-engineered T cells. Like, for example, you take any cancer, like for example, you know Hodgkin's lymphoma. Hodgkin's lymphoma, all of them have CD30. So now if you can actually take a T cell, genetically re-engineer this T cell so that it can attack CD30 and grow it in a lab and come and give it back to the patient, maybe it will work. Right. So now the problem here is the facility. These are all these facilities are expensive. They have to be US FDA approved. And as of now in India, I don't know any facility which has got the permission to manufacture CAR T cells. But I think our IITs and our other labs are working on it. I'm sure it will come. So this is just to give you a brief that immunotherapy is not only what we call checkpoint inhibitors. Today I'm going to talk predominantly about checkpoint inhibitors, which I have written last, but immunotherapy can be any treatment which can actually stimulate your own immune system. As simple as a BCG which you administer in a bladder. right? In urology OPD, if you go, if you have a urothelial cancer after a resection of the bladder tumor, the urologist will inject BCG inside. What is BCG? We all know what is BCG. And why do they do that? Because again, it causes inflammation and immune response. So that's also kind of an immunotherapy. So now we'll move only to checkpoint inhibitors. Now, checkpoint inhibitors, to understand that, you need to actually understand how your immune system works. You all know there are two components. One would be your immediate, the innate immunity, which produces a rapid response. It's your army of cells which attacks the tumor or the bacteria or the virus immediately, which comprises mainly of your neutrophils, eosinophils, basophils. But that's not most important. The most important one would be your adaptive immunity, which actually the main drivers of that is your T cells, and T cells can be both memory cells and you know, to kind of this main response of your adaptive immunity happens after your antigen presenting cells. What are antigen presenting cells? These are just macrophages, dendritic cells in your peripheral tissue, which engulfs a bacteria or a virus or a tumor, and once it does that, it will identify proteins, and those proteins are again presented to your T cells. And the presentation happens using your MHC class molecules. And once your T cells are presented these antigens, the T cells will again travel to the thymus, and then there you have your activation of your cytotoxic T lymphocytes, which gives rise to memory cells. Now, so this is all the basic immunology. Now, what happens in cancers is actually the moment your normal cells undergo something, like it could be a smoking related mutation, it could be an inherited genetic mutation, it could be some viral infection. The moment there is a hit and then there is a mutation, the normal cells will convert into an abnormal cells, what we call a cancer cells. The moment that happens, the T cells in your body, which are actually conducting what we call immune surveillance, will identify these cells, and usually most of the time in early every day all of us are undergoing mutations. Most of our cells, your hematopoietic cells, your mucosal lining of your gut, all the multiplying cells, there's so many mutations going on every day, and every day these mutated cells are actually eliminated. Sometimes what happens is elimination doesn't occur, and what the tumor cells achieve is what we call a phase of equilibrium. Now, by equilibrium, I would mean there's a constant fight going on, which it doesn't allow the cells the tumor to grow. And in some patients, what happens is that the tumor cells finally wins. The tumor produces, and it does that by secreting a lot of cytokines. The common ones are TGF-beta, interleukin 10, something called IDO, and this is what makes the tumor microenvironment very immunosuppressive. So therefore, it kind of not only escapes, but on the other hand, it can also even attack your T cells, which are trying to kill the cancer cells. Now, how does when we talk about checkpoint inhibitor, we need to understand what are these checkpoints, right? So the two main important checkpoints against which we have therapies available now, there is something called CTLF4, which is called cytotoxic T lymphocyte antigen 4. Now, what is cytotoxic T lymphocyte antigen 4? If you just look at this video, this is again this is a dendritic cell which has engulfed a tumor cells, and it's going to present its antigen to your T cell, right? How does this interaction happen? The first thing, as I mentioned, is the MHC molecule on the dendritic cell, which is going to bind to the T cell receptor, and this yellow thing here is the antigen which is going to present. So once that happens, there is stimulation of T cells, right? So now once you you stimulate a T cells and leave it alone, the T cell is going to do what? The T cell is going to remain turned on and is going to kind of destroy not only the tumor but also your body. So you need to have a mechanism by which this switching on is shut out at some point in time. And usually so this switching on usually happens by other molecules. One is called CD80 and CD86, which are present in dendritic cell, and CD28 is the molecule which is on the T cell. So this interaction is a positive interaction. The signal is positive here. As long as this is going on, the T cell will never switch off. So how does the T cell switch off? The T cell switches off by producing a protein which is called CTLF4. Now, if you just look here,
provides a negative regulatory cytotoxic.
See, the CTLA4 would actually come from the T cells and will displace these proteins, right? So this is just a delivery. So this is just I'm just trying to make it a bit more interesting by explaining to you what are these checkpoints. So CTLA4 is one of these checkpoints. Similarly, that's not the only one checkpoint. We've got various, and there is something called PDL1. There is something called OX40. So there are like the hundreds of checkpoints, and it's only recently, that is in 2018, these two gentlemen, this is Professor James Allison and Professor Honjo, which actually won the Nobel Prize in Physiology and Medicine in 2018. And the reason, their work was predominantly not on CTLA4 but on PDL1. And so what is this PDL1? So now I showed you a video on CTLA4. Now CTLA4 predominantly is present on T cells, and it kind of plays its role in the priming phase when the dendritic cell and the T cells are still in the lymph node. But what happens afterwards when the T cells goes and attacks the cancer cell, this black is the cancer cell, here again the same thing happens. The T cell is going to identify the cancer cells again through antigen presentation through MHC, and once that happens, the T cell is going to turn itself on and going to start attacking the cancer cells. And then once the T cell does that, the tumor cell becomes smart, and tumor cell expresses this protein called PDL, which is called program death ligand. Now PDL actually binds to a receptor called PD. This is called the program death receptor. There are various 1, 2, 3. So what is more important is PD1 and PDL1. So remember, the ligand is present on the tumor and the receptor is present on the T cell. Now, so if you can block this interaction, the tumor cell will not be able to switch off the T cell, and it will lead to excessive cell kill. And all this looks good in theory, but does it work in practice? So this is data from, this is survival data of patients who have metastatic melanoma. Now you know metastatic melanoma is a very difficult to treat disease, and this is data from 1975 to 2005. And if you see across clinical trials, most of these patients would die by almost 1 to 2 years, and it's only 5 to 10% of them would survive. But in the immunotherapy era, if you see, this is just one of the trials where for patients who receive immunotherapy with anti-CTLA4 antibody, which is called EP, and there is another PDL1 which is called Pembro, and you see it has made so much of a difference. Now this is probably exaggeration, because I'm talking only about melanoma. Melanoma is not a common cancer. The more common cancer is like what, lung cancer, breast cancer. You should ask me show me the data in those cancers. So which we will do in some time. Now this is just again to kind of explain to you further into about what exactly is this, how exactly does the tumor produces the PDL1 on its surface. So when your T cell contacts the tumor antigen, it secretes interferon gamma. Now interferon gamma would go and act on the tumor cells, and this is research done in a melanoma cell. When the interferon gamma acts on this receptor, which is called the interferon gamma receptor 1 and 2, and there is a signaling inside. This is through the pathway called Jakstat pathway. Now I'm telling you all this is because all these are potential targets. So people are working on them, and we may have drugs in future. And through this pathway, the tumor is actually able to express the PDL1. And once we have the PDL1 expression on the tumor cells, this signal is inhibitory signal, right? So it's the opposite of what you would expect. Now, so basically, by now you have realized that PDL1 can be an important biomarker. But so what does it mean? That should everybody who comes to you with a cancer, you just do an IHC PDL1 if your tumor is positive? Will he get cured with immunotherapy? We would want it that way, but it's not that simple. That is because PDL1 again is a dynamic biomarker. It is not a one-time thing. A tumor which is PDL1 negative today, after 2 cycles of chemotherapy, it may become PDL1 positive. Also, you should, as I've explained to you, PD-L1 is actually a stress response of the tumor itself. So the tumor is more stressed, it may express more PD-L1. Also, the challenge is how do you identify in the lab? So if I ask my pathologist, can you tell me what is the PD-L1 status? The pathologist will ask me what antibody you want to use. That's because, see, this is the same tumor which has been stained with 4 different antibodies. And you see that some pathologists may call this negative, some pathologists may call this strongly positive. So there is a lot of, and also there are studies which has shown that different parts of the same tumor may have different pattern of staining. So it is actually a challenge to kind of correctly characterize it, whether a tumor is PD-L1 high or low. And and also there are some stains like SP142 which also stains your immune cells for PD-L1. So it's also been shown that even your immune cell positivity is important, not only your tumor cells. So it's still an evolving field. We don't understand extremely well. But what we really understand is people who are positive for this biomarker, they do really well. I just showed you a slide on melanoma. We won't go into individual cancers, but this is just to tell you that these are the various cancers in which either in first line or in second line, these drugs have got a US FDA approval and they're available for use. And the cancers where it has made a major impact, I would say, is lung cancer, followed by renal cancers, followed by, I would say, Hodgkin's lymphoma. So much so that earlier you had relapsed Hodgkin's lymphoma, the only way out for them was transplant. But now a lot of those patients actually don't have to go for transplant. They can actually try these therapies. And then this field is evolving every year, every day we're trying to see various studies. This is just kind of to give you a picture of what kind of trials people do. So this is like a study, a randomized phase 3 trial in lung cancer, right? So this is a patient where you have diagnosed in your ward, he has come with cough, breathlessness, there is a lung mass, there is a lymph node metastasis. So that kind of a patient, when you send a MEDONC referral, we will usually come and discuss. What do we discuss? Chemotherapy, right? So we discuss chemotherapy because that's the approved best available option we have. But for but if you do a PD-L1 and your PD-L1 is high, do I need to give him chemotherapy, or can I just give him immunotherapy, or do I need to give him chemo plus immunotherapy together? So those are all the questions people are asking, and this is just one trial where the question they asked was chemotherapy versus only immunotherapy, no chemotherapy at all. And so there are various trials like this. There are almost 30 trials like this. I can't bore you with all that, but just to show you that in these kind of a trial design, the results, if you look at overall survival, the median overall survival in lung cancer has improved almost by about 10 to 15%. Right, so here if you see, this is PD-L1 expression, right from 1%, 20%, 50%, and these are survival. So here the median survival with chemo was 12 months versus 20 months. So that's the median. So if you look at the curves, this is the results from this particular study which I showed you. Overall, if you see, okay, I mean some difference, but you may not be impressed. You may say, okay, it's only about 3 months, but these are all comers, irrespective of their PD-L1 expression. If you see patients who had high expression of PD-L1, the hazard ratio is 0.59, which which corresponds to almost a 41% reduction in your risk of death. Right? So this is a big thing, and I wouldn't tell you to focus more on the difference, but what people are getting excited about is actually the plateauing of the curve. So usually cancer curves, Kaplan-Meier curves, you will expect them to come, and at some point in time, 2-3 years, everybody should be dead. Right? That is how curves you expect. But with immunotherapy, what's happening is the tail of the curve is plateauing for even this is across cancers for almost about 20% of patients. So this 20% of patients are actually long-term survivors. Some of them 5 years, 10 years. And they are the ones who are probably responsible for the higher median, and so that's something which has excited all of us. And this is just these are all 4 different studies, 4 different molecules. Pembro is one, the other one is Durva, the third one is Atizo, and you see similar separation of survival curves. So much so that today, if you are in the US and money is not a constraint, if you have a lung cancer, the pathologist will not see, the oncologist will talk to you only after your PD-L1 results have come. And based on the PD-L1 expression, if you see, if your PD-L1 is more than 50%, we are very confident in telling that you will do better than chemotherapy if you just take immunotherapy. For all lower expressions, you will do better if immuno is combined with chemotherapy. So as of now, we are not moving. So that is lung cancer. Now quickly just few examples on kidney cancer. Now kidney cancer, again, as you all have known, that it's a cancer which is so difficult to treat because chemotherapy never worked in kidney cancer. All what worked was initial days, it was this oral tyrosine kinase inhibitor called sorafenib or sunitinib, and subsequently we had these medicines called bevacizumab, which was an anti-angiogenesis inhibitor. But of late, if you see, there have been approval of about 4 newer therapies, and all of these contains immunotherapy as one option. Now this table is just our survival figures in olden days. By olden days I mean just 10 years ago. When you see the standard of care was sunitinib, and it was compared to interferon alpha, and there if you see the overall median progression free survival was 5 versus 11 months, and the overall survival used to be in the range of about these are all good risk patients, about 2 years. Now today, if there is a renal cancer patient, if you have an option of giving him sunitinib, which is an oral drug, versus immunotherapy, and if you give him immunotherapy, you can expect better results. And if you see here, here the median survival is not even reached. That means the curve is still not crossed the 50% mark. So I'm just trying to show you is that in difficult to treat cancers where we had no options, chemotherapy was useless, these things have actually made a bigger impact as opposed to cancers like breast cancers, GI cancers, where chemotherapy is still the best, and these agents have not made an impact. Now the field is moving forward. People are trying to not use these agents as a single drug, but they are trying to combine it with other ways by which we can enhance this whole cancer immunity cycle. That means you're combining it with chemotherapy so that there's more antigen release. You're combining it with radiotherapy, there can be more antigen release. You're combining it with anti-angiogenic inhibitors, so that you can actually work on tumor microenvironment. Also, you can combine it with cancer vaccines. You can combine it with cytokines. So maybe vaccine plus immunotherapy with the checkpoint inhibitor may be better than vaccine alone. Also, now because we are not directly attacking the tumor cells, the tumor microenvironment becomes extremely important. A lot of work is going on trying to understand what makes the tumor microenvironment so immunosuppressive, and why is it that our T cells don't reach or don't survive. And the two bad guys, the two bad cells in this microenvironment is, one is the regulatory T cells, which kind of not only they kind of attack your regular T cells, they also try to switch them off. So by different molecules like this LAG3, and I'm not going to bore you, but there are clinical trials which are actually studying LAG3 antibodies. So that is how the field is evolving. And also the other bad cell is something called myeloid derived stem cell, which again is these are the two guys. If we are able to inhibit, we may be able to make response. Another interesting thing which people have discovered is actually your immune system, we still don't understand it properly. It's like your gut microbiome. It's the kind of the bacteria which you're carrying in your gut can actually determine the kind of response you will mount to immunotherapy. So much so that they have shown that for patients who were treated with antibiotics in the last 3 months, and maybe their gut microbiome had changed, they did not respond so well as opposed to somebody who did not receive any antibiotics. Also, people have shown in human experiments that if you do FMT, the fecal transplantation from bacteria, you take bacteria from someone who has responded to immunotherapy and you do a transplantation, that person who did not respond to immunotherapy actually begins to respond. So we really kind of we are still scratching the surface. We still don't understand what exactly how are all these things linked together. And this is a slide just to show you the different checkpoints against which the trials are ongoing. As of now, approved drugs are only for PD-L1 and PD-1. Also, other than PD-1, there is also another thing which you may come across is something called tumor mutation burden. Now, tumor mutation burden is basically, you all know most tumors have mutations, but some tumors have more and some have less. Can you measure it? Now, the way to measure it is now with this next-gen sequencing, when you sequence the entire tumor, the software will actually tell you the number of mutations per megabase of DNA studied, right? So, and based on this, you can actually divide high tumor mutation burden, intermediate or low, and these class of drugs have better efficacy if your TMB is high. The logic is that if you have more mutations, maybe you have more antigen release, your T cells are recognizing the tumor more, as opposed to if you have a few mutations which your T cells cannot. So there is something called if you all know Lynch syndrome, in Lynch syndrome, you do get a lot of mutations, and those tumors, the pathologists will call them microsatellite unstable tumor, what we also call MSI high. So MSI high is actually a surrogate which we can test for, which can tell you if the tumor is MSI high, it will have a high TMB. And I'm telling you all this because if you have a patient who has an MSI high tumor, they can be given immunotherapy and they do really well. You don't have to do chemotherapy. So as of now, for us, for every metastatic GI cancers which we see in our OPD, we do test for MSI, and that's like our surrogate for tumor mutation burden. This is just to kind of show you different. I won't go into these, but these are all different trials which have just shown you response rates of 20 to 30%, and these are all again a list of conditions where this one single drug is approved for use, and these are all individual cancers, and this is just a picture of number of molecules which are currently being studied. These are across different cancers. So ovarian cancer, breast cancer, head and neck cancer, urothelial cancer, renal, melanoma, small cell lung cancer, non-small cell, and hematolymphoid, colorectal, pancreatic, liver. So that's how. So now, like earlier, people would say like there were three pillars of cancer treatment: was surgery, chemotherapy, and radiotherapy. Now possibly immunotherapy in future would be the fourth pillar. Now let's a few minutes into toxicities. I mean, how toxic are these drugs? Now, if you compare their toxicity with chemotherapy, definitely they have a very different kind of toxicities. Now, as you can imagine, you are trying to cause a T cell stimulation and a cytokine storm and immune response. So their toxicities are usually what you will see in rheumatology, those autoimmune diseases. Right? So in rheumatology, what do you see? Autoimmune diseases can involve any organ system. It can involve from head to toe, and it can cause organ damage depending on the severity. So similarly with these drugs, you can get, if you go from head to toe, it can cause what we call a hypophysitis. Now hypophysitis is your inflammation of your pituitary, and then it will manifest as low growth hormone and diabetes, electrolyte abnormalities, headache, blurring of vision, and so then the dreadful ones are usually what we call pneumonitis. So you have patients who get the infusion, goes home, comes back with fever, cough, and breathlessness. I mean, in current era it will be COVID, but earlier if you had immunotherapy, we would think of immune-mediated pneumonitis. You can get a hepatitis, you can get a fulminant hepatitis even with one infusion. Rarely you can get a myocarditis. You can also get colitis. So colitis, pneumonitis, hepatitis, these are the three which we worry about. And the other uncommon ones would be your endocrine, like hypothyroidism and all is very common, almost 30% of our patients. But that's again, it's like a Hashimoto's thyroiditis, which you can manage with thing. Very rarely you can have like a myelitis and encephalitis. And we've had a patient who had a Guillain-Barré. So sometimes this can be very crippling. And but the good thing is the incidence of all these grade 3 to 5 immune-related adverse event is actually pretty low. So when I say pretty low, that means they are in not even 2%. So they're all in like 1%, 2% range. And most of them are actually lower grades. By lower grade, I mean patient can be managed as an outpatient. and it's only when it becomes grade 3 you may have to admit and treat the patients with immunosuppressants. Now when we have combination immunotherapies, even though the responses improve, the toxicities also improve, toxicities also increase. Like for example, if you give Nivo plus EP, the toxicities is going to be higher if you just give EP alone or Nivo alone. Also, these toxicities are dose dependent. Now in many of the recent trials, when you're able to reduce the dose, the toxicity actually comes down. And also most of the toxicities occur in the first few months or weeks, and then later the patients actually tolerate it quite well. This is just a picture to show you when do you expect a particular kind of toxicity. Like for example, if you have diarrhea that usually occurs in the 5th week, peaks around 8 to, and then by after 10 weeks, if somebody has not had a colitis, very unlikely he'll have a colitis. So this is reassuring that most of the toxicities occurs early. Now, in many patients, when they have severe toxicity, we stop this treatment. But even then, the reports suggest that once you have stimulated your immune system and produced the toxicity, they actually do well. Even after you have, maybe your memory T cells are still linger around and your cancers remain under control. So actually, in the trials, patients who have had toxicity and they have not died, actually they have lived the longest. And now people are even trying to reintroduce reintroduce these drugs. Now the general principle, this is pretty simple. I mean, for mild to moderate, you don't do anything, you just hold the drug. But for severe, individual toxicities are defined what is severe. For hepatitis, what is severe for colitis. You start with steroids, prednisolone, and then if you don't get a rapid response, then you go up to the second line, like you can use methylprednisolone, you can use infliximab, you can use etanercept and mycophenolate, all those drugs. And so here the important thing is there is nothing called dose reduction. Once you have a severe toxicity, you stop, wait for it to recover, and then you re-challenge later. So with that, I think I'll conclude. So in summary, you will hear a lot about anti-PD-1 and anti-PD-L1, which has so far has been the most effective class of drugs, and in future they'll probably form the backbone. And in the clinic, we generally look at PD-1 expression. We also sometimes look at tumor cells infiltration in the tumor. So something what we call TIL, tumor infiltrating lymphocytes. The pathologist can give you a score. And also, like in coming days, we will be possibly we'll be able to understand how do tumor cells develop resistance to these drugs, how to make a particular tumor which is cold. By cold I mean tumor cells are not with lesser T cell infiltration. How we can turn them hot? Should it be with radiotherapy? Should it be with chemotherapy or something else? So that's how the field is evolving. And also, as of now, I think it's just we don't understand too much, and even so much so that we even don't understand the exact doses. I mean, most of the doses and the schedules is actually decided by the pharmaceutical company, and they have done the trials which will which will bring profits for them. And in our country, where the cost is a problem, even in Asian, Korean countries, people are trying lower doses, longer, lesser dosing schedules, and outcomes are pretty good. So with that, I'll close. And is there
so for making it a simple way so that we could understand. So it's open to any questions now from the audience.
Very comprehensive, Ashish. Thank you very much. This is about long-term side effects, because you are playing with the immune system, both in terms of autoimmune disorders and unique opportunistic infections. Any issues? This is outside. Follow up these patients long-term.
Sir, opportunistic infection, I mean, I'm not sure if these patients become immunosuppressed and they have opportunistic infection. At least I haven't seen any such reports. And regarding long-term, I mean, other chronic autoimmune diseases, It's like actually most of the approvals and trials, if you see, they're all in advanced metastatic patients. So most of these patients may not live that long. That is number one. So what you're asking is that data maybe we don't have. But whatever we have as of now, the life-threatening ones are these which happens within first 3-4 months. It's not that they can't happen later. Most of them happens earlier. And the chronic ones are mainly these endocrine disorders, dry skin, Sjogren's, neuropathy, those kind of things which can be chronic.
First of all, thank you, Ashish, for agreeing. Thank you that you'll.
I think
Coming months, you can have more
there.
talks. Just another question. One more person needs a mic in the back. This BCG vaccination, again, because of COVID, has again become a thing. In any other cancers other than bladder, has this general immune stimulation helped?
It causes a non-specific kind of an inflammation. Now, there are some reports where even for melanomas, earlier days when we didn't have these drugs, we used to inject intradermally these BCG vaccines and give some interferon alpha 2b, something like that. And actually Dr. Raju will say he has 2-3 patients who have done well, but we actually tried on one patient and he developed a BCG infection. He developed a hepatitis and we had to give him ATT. So I'll say these are all very non-specific, sir, and most of the time the tumor is smart and it kind of learns and grows.
Wow.
Thank you very much. You had mentioned that the gut microbiome species can make a difference as to the effectiveness of the immunotherapy. Can you tell us any more about that and which species of the gut microbiome
No, so there is no particular kind of, there's a lot of, if you see cancer immunotherapy gut microbiome, there are a lot of papers, mainly in Nature. If you just go through Nature, so it's not exactly one species which is good or one species which is bad. So people are still trying to understand. They're trying to look at, okay, whether if you take these lactobacillus or these, what do we call it? These, when we get a diarrhea, these pediatricians, they keep giving. Probiotics, yeah. So when they say, there are a lot of studies whether probiotics is going to be useful, not useful. As of now, what it shows is probiotics do not work. So you cannot kind of it's not as simple as that. And it's basically, it's also to do with how your body interacts with your microbiome. And we still don't understand it. But what we know is, if someone is responding, his microbiome is a good microbiome. And if we understand better, we can possibly replicate that in other patients who are not responding.
So people have taken their stool, taken the microbiome and transplanted.
Yeah, so they've taken stool samples, given it through Ryle's tube, and it's like a transplant.
Any other questions? Any other postgraduates want to ask anything? Let's give Dr. Ashish a big hand. Thank you very much, Ashish. Very honored.